this panel discussion. I would just like to tell you about this. What's a panel? Being in medical education unit, we just talk about different methods of teaching, different teaching learning methodologies. So panel is a large group teaching methodology, and we usually take panel discussion for topics that are related to the attitudinal domain. So like it could be HIV, something where we usually have even a patient and a supporting relative and all that. So this is related to the blood bank, and to discuss a lot of these issues, we have called it as a panel, and panel has different panelists, so it cuts down the monotony that comes when you have only one speaker speaking about a lot of things. So I will be moderating this panel, and the panelists, I request the panelists to please come on to the dais. I have Dr. B.S. Prasad, Director of Neonatology, who is using a lot of blood and blood products to save the newborns. I request Dr. Sundar once again to be with us. It's a continuous session for him. I think Dr. Sundar's introduction, Shweta has done, but I just need to say that we studied in the same college. So I've seen him since 1980. So we were at BMC, he's my senior in BMC, as pioneer in transfusion medicine. I request Dr. Prakash Hiremut, a cardiac surgeon who uses lots and lots of blood. So when it comes to blood and blood products, I should say we had stopped using whole blood. Minimize the use of whole blood, but when it comes to cardiac surgery, I think it demands whole blood. And so if at all we are using whole blood in our component blood bank, it's for the cardiac surgery. I request Dr. Narendra, Head of the Department of Emergency Medicine. He's one of the panelists. So emergency. So we know various emergencies which require blood, and I'm sure a blood bank is helping them to save these patients. I request Dr. Gayatri Patil, Professor of OBG. So I need to say Department of OBG, all the consultants are very happy with the services of the blood bank because they need blood and blood products day in and out. In spite of being on leave, Dr. Gayatri Patil is here to be one of the panelists. Dr. Reggie, Professor of Surgery, is with us. I request him to be with us as one of the panelists. This panel discussion is scheduled for 90 minutes. Yeah, 90 minutes. And a lot of questions the panelists are put forth is what probably the audience has. And one more thing, I would request, if you have any questions, to please hand over the questions to me. The young doctors, I think, interns' point of view, I don't know whether I would be able to discuss, ask them some questions. And we start with first question to Dr. Sundar. I'm sorry I'm not giving you any break. People may wonder, we have called this as CME on good transfusion practices. So they may be wondering as to what is this good transfusion practice. You will just tell them about this and I'll take the other questions.
The question is too big to answer. So it's a gamut of the practice starting from blood collection to transfusion. We call it as vein to vein. So we should have a quality starting from the donor, selection of the donor, donor who is eligible, a healthy voluntary donor. and he is willing donor, and donor must be a voluntary donor. Blood should not be collected from relatives. Blood should not be collected from a person who is unwilling. That is, coercion should not be applied. No force should not be applied to any donation. And at present we have in Karnataka we have about 70% voluntary donation. 30% of blood is still coming from family donation and relatives and friends donation. So we, over a period of time, we should take away all this relative donation. We should be at say in 2-3 years we should have 100% voluntary donation, because you know already the patient is in patient's family is in the stress because one of the patients is admitted in the hospital, on which we are telling them to donate blood. It is immoral. It's not a good thing to force them to donate blood. That's the most important thing. And donor can only donate once in 3 months. There are few donors, Bombay blood group donors. They would have donated yesterday, and another patient will ask them to donate today. It is not possible. So quality of the blood will not be there. There are people, private blood bank people who will be catching hold of on negative blood, say B negative blood. They will keep on bleeding him every month. Actually, the guideline says you should bleed once in 3 months. So the good practices starts from blood donation. Then after that, the blood has to be processed, stored in proper way. The processing is that we have to do mandatory tests. In additional tests can be made. In Karnataka, the first state in Karnataka is to do NAT testing for all NAC-hosted blood bank. They are spending 1,000 rupees for every donation for doing a NAT test on HIV, hepatitis B, and malaria. The best quality is in Karnataka. That's one thing. And that is additional test. We can also use P24 test in newborn babies, and we can do cytomegalovirus test for cytomegalovirus, toxoplasma, and we can also do some additional procedure called irradiation to prevent the graft versus host disease. Sometimes we have to remove the leukocytes. We call leukoreduction. So this is one of the procedure to avoid alloimmunization to the patient. So this all comes under the good practices in the processing. Then proper transfusion. In this blood also, we know that this is split into different components because you know the whole blood. There is no single medical condition in which whole blood transfusion is required. A patient suffering from anemia, his hemoglobin is less, so you give him hemoglobin only. So you cannot remove hemoglobin, and it is toxic to the kidney. So we have to transfuse one red cell. So red cell only red cell is required. And for thalassemia patient who require repeated transfusion, they also have low hemoglobin. Actually, basically they have a problem in globin chain, beta globin chain or alpha globin chain. If you correct that one, that is a perfect treatment. But we are not able to give hemoglobin. We are able to give only red cell. So the remaining things should not be given because they are getting repeated transfusion. Alloimmunization, allergic reaction is very common in a patient who requires repeated transfusion. So plasma is required for other conditions like mainly to replace the coagulation factors. Cryoprecipitate is required only to replace coagulation factors. Platelet is required only for patients having thrombocytopenia, which is less than 20,000 per microliter, not even patients suffering from thrombocytopenia, just 1 lakh or 50,000 per microliter, for whom platelet transfusion is not at all required. So you see a single unit of blood is different to different component given to different conditions. So I don't see any single indication for which whole blood is required. Maybe it is because maybe.
I think the cardiac surgery they require. I have taken that question with Dr. Greenberg. Thanks, Dr. Sundar. I think it's huge, as you said, to define what is good transfusion practices. But you have told, starting from selecting a donor to the use of all the blood and blood products. See, every 2 seconds, someone needs blood. It may be you or me or our kin and kin. And 1 out of 10 patients in every hospital, they require blood. And when I say one, every 2 seconds someone, so it could be an emergency as we say. So I have a question for Dr. Narendra who deals with emergency cases. So it is, I think, a hypovolemic shock that where you require our support to treat the patients. I think you can just take up this as you've given probably a case scenario and tell them how you manage this hypovolemic shock.
I'll just give the brief case history of what we have encountered in an emergency. A 34-year-old male patient was brought to the emergency department with early history of accidental run-over by a train at around 10:30 a.m. on 16/6 near Harrier railway station. You know where the this was? It was just there was no pulse or pressure, BP was not recordable with very feeble pulse. The patient generally will be conscious at this stage. So the treatment what we gave was we started to do large bore cannulas, that is 16 and 18 gauge in both the upper limbs, and we started as while putting the cannula we took a few blood samples for routine blood grouping, cross matching, and then further if HIV, basic and other parameters. So in the meanwhile we transfused about 1.5 liters of normal saline, that's fluid of choice in any hypovolemic shock. And then one of the this thing is one more fluid was MSL, which we transfused about around 1000 ml, which was transfused immediately. So at that time the recent parameters what they say is now to maintain the blood pressure around 90 mmHg. So systolic, that's the maximum pressure what you can build up, not in the previous previous thoughts where you to bring up this was normal pressure of 120 or 130 mmHg. So we got it up to the 90, and then even that the patient was not maintaining. So a requisition was sent to the blood bank saying that we need a whole blood for transfusion, and then immediately O negative was given, and then we transfused 1 part of O negative blood, and for further requisition for RBCs and then whole blood it came a bit late. So because there are no donors available for the for the transfusion to be donated. Then after that the patient was put on ventilator and stabilized with the further.
Okay, I think one remark of Dr. Narendra, he says no donors available, that should never be there. As Sundar said, the relatives and friends who are there should never be forced upon. I'm sure we are meeting with the demands because as such when we look at the district statistics, the required amount of units of blood is 23,000 and order. The entire district DAP officer says we have met with the requirement and
one thing was immediately the blood was given O negative without any this thing.
Only because probably it was O negative there was so this is a hypovolemic shock you manage in the emergency. Now coming to Dr. Prasad, so he uses lots of blood and blood components in the neonatology unit. So name anything. Is it pathology or is it platelets? Is it cryo? Is it FLP? So what are the different diseases for which you use, and which is the most commonly used blood product by you in your practice, Dr. Prasad, neonatology?
Thank you very much, Dr. Shashikala. Regarding the blood and blood products transfusion in neonatology, It is, whenever we deal with a patient, I remember three approaches. I remember three alphabet E's. One is ethics, other one is empathy, and the third one is epidemiological approach. And when it comes to the third E, baby is different from adults, both from physiology, anatomy, and the blood. Just briefly, the blood volume of baby is 70 to 80 ml per kg. Baby is 3 kilo. The total blood volume of baby is 240 ml or around 250 ml. So this is, when it comes to the transfusion or any disease, we always think of prevention. So there is a new evidence which has come how to prevent anemia in newborns. One is both in premature babies and in term babies. What is this new evidence? Anybody from the audience? Where one of the prevention strategies for anemia prevention and in turn blood transfusion, because blood transfusion has got its own hazards. It's not a simple thing. But, there's one new evidence which has come, which is very easy, and it's in the area of perinatology. It's an evidence-based medicine. Dr. Sundar showed the different levels of evidence, and this evidence comes at grade 1, done by randomized controlled trial. That is cord clamping, delaying cord clamping, for especially the nurses working in OBG department. If once the baby is born normal, without any bad obstetric history or any risk factors, if you can delay cord clamping by 1 minute, and the evidence is between 1 and 3 minutes after delivery of the baby, and once the cord comes up, if you can delay clamp the cord between 1 and 3 minutes, evidence has shown that the later the anemia and the hematologic indices are better, and in premature babies, the anemia of prematurity is less, and later blood transfusion incidences are less. That's one thing. And what's the next question?
Different components, I said.
Yeah,
Which is that component you're using?
before going into the different components, the different components we use in neonatology, one is the most used is packed RBCs, PRBCs. That means packed red blood cells. It's not whole blood. Okay, that's the one we commonly use. And during following the next rotation, we will come to that when we use white here. And the next one we use commonly is fresh frozen plasma, which is the plasma separated from the blood after centrifuging the whole blood. You get the supernatant fluid, the plasma, and then they froze the blood bank, the hematologist, they freeze this separated plasma at different degrees, and that's kept, and it's got a long shelf life, and that's the one we use commonly now. And the third one which nowadays we commonly use, and I am very proud of our hematology department and blood bank, cryoprecipitate, which is available in Davangere only in our center. It's not nowhere else available. It's really precious, cryoprecipitate. And probably Pathology Hospital is now there.
Yeah, Dr. Jagdishwari says it's available there because recently they started a component separation unit at blood bank of Bapuji. Yeah.
Cryoprecipitate is nothing but once you centrifuge this plasma and thaw this centrifuge plasma, you get a sediment. Plasma is a supernatant. The sediment from this FFP or plasma is cryoprecipitate. You remove the supernatant fluid, and the remaining sediment is cryoprecipitate, which is very rich in all the concentrates of the drug products, mainly your coagulation factors, especially fibrinogen and all those things. We use whole blood. It's very rarely in few other conditions. And the next blood product what we use is there is something called factor concentrates. Factor 8, hemophilia A. We down here has got a hemophilia society. Factor 8 is available down here. Many of us don't know there is a hemophilia society. Our team is also collaborated with hemophilia, and they get this factor 8. And if a hemophilia, known hemophilia child comes, we use factor 8. And in Western countries, hemophilia is diagnosed in utero. The baby has got hemophilia or not, and if that baby is born, male baby, already the protocol is ready, factor 8 is ready, everything is ready with you. That's a fantastic quality. You give immediately and send the blood, give factor 8 depending upon the level, degree of hemophilia.
Yeah.
So these are the blood products we use. And one more product we use, the blood product. Anybody knows that? One more blood product we use, erythropoietin. Somebody said erythropoietin, very good. Erythropoietin we use. there are certain indications. Our nephrologist here is smiling. Why is missing erythropoietin? They use that in chronic renal failure with anemia, but in prematurity we use erythropoietin. We'll come back with later. So these are the blood products we use. Thank you very much.
Yeah, thank you, Dr. Prasad. So one thing we noticed is least used is the whole blood. So, but I told you, I repeatedly told you about the whole blood. And when it comes to cardiac surgery, they need whole blood. Even today, I had a request from a private hospital because for a patient with double valve replacement, he was asking for 4 units of whole blood. So I think Dr. Hiremat, our cardiac surgeon, would throw light on the usage of whole blood for the cardiac surgeries.
Actually, it is a wrong concept that whole blood is used. As Dr. Prasad has said, the use of whole blood is very, very rare nowadays. It is fractionations, that is packed cells, platelets, and transfusion plasma are the 3 components which are very regularly used in cardiac surgery. Whole blood we use wherein we find a situation we don't want to overload the patient, at the same time we need some volume to be replaced, but it should be a colloid. In that situations only we use whole blood. Otherwise, actually, internationally or the whole world, you take in any sectors, use of whole blood has been actually, it has come down remarkably. It's only the fractions. Because if you want, it is to avoid the overload of the patient. And especially in cardiac patients, they may be congestive failure, they may be having a lot of liver problems, and when they are coming, they are almost in class 4. So they have all the organ involvement, especially the liver. So we don't want to overload the patient. In that situations, we use only fractions. So most of the times we use packed cells, platelets, isolated, and many times suppose we are unable to control bleeding, we may use cryoprecipitate. Otherwise, it is only fresh frozen plasma and packed cells is the most common.
Yeah, but what I said was the request what we get for the blood bank or whole blood is from the cardiac surgery unit.
No, it is wrong. It is wrong. It is. I don't know why they have asked for it, but you have seen what we request regularly is only packed cells. But one whole blood, what we are regularly asking is only for volume replacements in case we need.
Yeah. So volume replacement, as a cardiac surgeon says, that is where he requires whole blood, and it's mainly, I need to say the blood bank, if at all, if we have few units of whole blood, so it is mostly to cater to the cardiology, I mean their cardiac setup. And whenever we say, we talk about the use of blood, surgery is the one thing, that comes to everybody's mind. So missing Dr. L.S. Patil, oncosurgeon here, who needs lots of blood for the surgery he takes upon for the oncosurgery. But I have Dr. Gidji, who is a professor and HOD of surgery with me, said about your blood and blood products, what you use for your patients.
So there are guidelines. Whenever we anticipate there is a lot of bleeding on the table, sometimes we transpose blood. Before that, we check the HB percentage of the patient. There are 2 guidelines. Usually, there was a old thought that it should be 10 grams per 100 ml deciliter. But now, even if it is 8 also, and if we don't anticipate bleeding, we don't usually call for the blood, or sometimes we reserve the blood than drawing the blood. And when we anticipate lot of bleeding, especially in thyroid surgeries and all, so especially in case of thyrotoxicosis, or the patient is very in hypertension. And many times we also join our hands with the anesthetist to have a hypotensive anesthesia so that the bleeding will be minimal. And preoperatively, when we are taking the patient on elective basis, we control the blood pressure. Otherwise, we anticipate lot of bleeding. So whenever there is a dire emergency or when we expect a lot of bleeding, then only we call for the blood transfusion. Otherwise, the blood transfusion is always restricted. And sometimes the 20% of blood loss can be treated with the IV fluids, crystalloids, colloids and all. But we also keep the blood reserve only when we anticipate there is a bleeding.
Thank you. Thank you, sir. I think recently, I heard Gayatri thanking the blood bank. You know for what? There was one patient for whom she used about 15 or 20 units of various blood components. She was very happy. She said, yeah, I have done my job, I have saved the case. So what could that be? What are these days emergencies that OBG or obstetrician or the gynecologist faces? So she would be giving us the scenario, and it is DRC, as all of us know. So how is it the blood and blood products that are being used? So it's over to Gayatri. She would present a case and then make you know about the importance and the use of various blood products in this case.
Very good afternoon to all of you. I would like to thank Shashikala madam for involving me in this panel discussion. And we are very thankful to our blood bank, because they have literally cooperated with us in all the emergencies. We face emergencies in and out. For example, we have cases like ectopic pregnancy coming with 2 grams HB. We had rupture uterus coming at 3 grams. We had a very sad story very recently, very fresh with us. This is a young patient, 21-year-old, who has been referred from a sister concern hospital. I don't know what they referred. Probably they think our blood bank is better than theirs. And so she came with 9 months of amenorrhea, severe pregnancy-induced hypertension with intrauterine death of the fetus in active labor with HELP syndrome. HELP syndrome is something called as, it's a form where the severe PIH leads to hemolysis, elevated liver enzymes, and this coagulation profile is abnormal in these cases. So she came with DIC, and she was in active labor. It was not good on our part also to refer her again here, because she was already 8 centimeters dilated, in active labor. BP was high, and she was ectric, she was pale, but conscious. She was experiencing labor pain. So what we did was, our first aim is to send the relevant investigations. Then we put her on the labor table, accelerated labor. She delivered in 1 hour's time. Probably 1 hour of admission she delivered. But she ended up with postpartum hemorrhage, because already her coagulation profile was abnormal. With that, she had a small lateral vaginal tear. We sutured, but again that started bleeding. So we thought we'll take her up for a exploration under anesthesia. So we did that. On table, sudden hypotension. And by that time, by 1 hour's time also, we had not arranged enough blood. We had sent the request, so the blood was on the way. So what the anesthetist said was, don't remove the vaginal pack until we stabilize her. So they started with inotropes, they started IV fluid, they gave her Lamaxib. They literally reloaded her with fluids till the blood came. That took 15 minutes probably. In 15 minutes time, we had blood. We took a lot of Paxils, I think 4 Paxils, 4 FFPs, 1 cryo, and I think there were only 2 platelets which they could give at that time. So 2 platelets were given. But the decision then was we had to use other blood group platelets. Platelets don't matter, they say, but for a young reproductive age lady, we preferably choose the same blood group platelets. But that was a crisis for us. We had to accept the other blood group platelets. So we did the procedure. That took just 15 minutes, but she went back to the ICU with inotrope support, ventilatory support, with severe sepsis. But every day the transfusions were going on. It is such a case, there was hypovolemia with overload. There were 2 things in one patient. Very, very difficult for us to decide. We can't give extra fluids because she's already had pulmonary pleural effusion. Bilateral effusions were there, not maintaining pressures. Inotropes with just BP of I think 90, 60, 110, 550. That was the maximum BP which she would have. She was not throwing any urine. There was a sinus, but hypovolemia is there. HP is just 7, 6.5. INR is never coming up. It is 1.7, 2.1. There is jaundice, liver is not improving, there is renal shutdown, hypovolemia is there, we can't give anything extra. Fluids are just 50 ml per minute. RT feeds are started. Now how to treat such a patient when there is hypovolemia with overload? I think Dr. Sundar or Dr. Shashikala madam can throw some light on this management. We just manage her with whatever fluids and blood and blood products we had here. Ultimately the patient didn't survive. It's a sad story of this young lady where we have three main reasons here. There is sepsis, there is this pregnancy-induced hypertension, there is hemorrhage, which are three main causes for maternal mortality in our country, still exist. Dr. Sundar, can you just tell us how to manage it?
I think though out of the panel, I would like to involve Dr. Kavita, who has been actively engaged and helping the clinician. She is the chief blood bank officer, I should say. So I just request Kavita to speak about this.
Hypovolemia as well as overload. So to decide how to go about it, I think series of continuous 4 days you managed with packed cells, platelets and FFP, right? So if she had signs of DIC, I think FFP was advised, but if it was not controlling and was not coming to normal, your INR was almost high, so you had to continue with FFP, and of course to maintain the hemoglobin, packed red blood cells is the choice, the component of choice. So
Then we started, the next day when she went for renal dialysis, they said we can give the same during dialysis, so that reduces the overload. But didn't help much. The coagulation profile never improved, the renal system didn't take up, the liver didn't improve. So we were left with very few options. Like every day we gave 2 packed cells, 2 FFPs during dialysis. Next day 2 FFPs, 2 platelets, 1 packed cell during dialysis. The third day she had lung collapse with effusion. So that even made decision worse. She couldn't even maintain oxygen saturation of about 67, I think was the last saturation, with highest ventilatory pressures. And there was sepsis going on. So then we said this is multi-organ dysfunction syndrome and with DIC. So it was like a dilemma for us. How much to give, what to give with CV. Yeah, thank you.
Two things what I observed in the discussion is that platelet count was not mentioned to us.
it was low, sir.
What is the
77, it came, it fell to 47, and on the last day it was 25,000. We could only manage with
Sir, this is one thing we always face a problem regarding the platelet count. I think for platelet transfusion the trigger is 5,000 and below. But most of the clinicians are very anxious to maintain the levels above 40 or 50,000 so that they are on the safer side. But I don't know in such a case whether in DIC if the platelet count is around 25, should they really go for platelet transfusion? Is it required or not? Is the question. So,
okay, the platelet was one is thing. Another thing is INR, what Madam was telling is 1.7, 1.7. Even for the certain condition, clinician would like to maintain the INR at 2. That means even at 2, patient do not treat. So that means FFP that was transfused was enough. A little more could have been given, but FFP because of the overload, they could have given cryoprecipitate. Quantity of cryoprecipitate is only 10 ml. So in order to avoid hypervolemia, we could have avoided transfusion plasma, but have given cryoprecipitate. That would give all the Lagai coagulation factor, including fibrinogen. And platelet, of course, even a 20,000 patient would not bleed. I don't know what is the reason for bleeding because of the hypertension. Maybe it is hypertension that would have been could have effectively treated. Hypertension could have been treated, but
She stopped bleeding.
6 grams.
Only one day she had to bleed.
So hemoglobin
Second,
also
third day
6.
and all that, there was no bleeding absolutely.
6 gram, 7 gram hemoglobin also would have taken care of the oxygen saturation. Maybe because of the DIC, the oxygen is sepsis, it does not been made. Thank you.
So could we prevent using platelets in such conditions?
So we are scared for the one day post delivery that she might, because 25 24 hours after delivery is the time where maximum PPH can happen. So we preferably keep them a little higher for the platelets. It prevents that she should not bleed, because each bout of bleeding in such a patient will literally put the BP down, hypertension. So on table with very minimal, probably she would have lost some 300 ml of blood. She became so bad, BP was like 20, 30 in there. So literally pulse was not palpable. We were scared whether we lose her on the table. So with that crisis she came up. And then maintained for 4 days. 4 days there was no gross improvement with all the measures which we took. And we had another patient who came with active labor. She was like 3 centimeters. She came at night, 1 o'clock. She was referred from Chitradurga with...
Is it a similar case or a different case?
This is a different case.
Can we just take up next? We have a second case that Dr. Gayatri will be discussing later. But I thought the next question would be for Dr. Prasad, but no, we have spoken so much about the platelet transfusions here. Just 1 or 2 words about platelet transfusion from Dr. Sundar. When we started platelet transfusion, so we said we are giving group-specific platelets. So why we started that was still, we had to standardize, and our platelets were getting mixed with RBCs. So though it was minimal RBC contamination, still they said the group specific. That's how probably we put all this into the clinician's mind, that the platelet that they give, that they order or request for should be group specific. So now as Dr. Gayatri put forth in a discussion like we could give other, but this was a lady in the reproductive age group. So I just want Sundar to clarify about the platelets. Should they be group specific? We know it's not, but what about in the reproductive age group? Just these 2 points for the audience.
Platelets are available in 2 forms. One is random donor platelet. That's a platelet that is available in the blood bank. And another one is single donor platelet or apheresis platelet. Is not available in Davangere entry, but it's available plenty in Bangalore, which is collected from a single person, and the platelet content is more than 8 to 10 times more than the random donor platelet. In the random donor platelet, the quantity is about 50 ml, and the number of platelet that is present is 3.5, 4.5 into 10 to the power 10. That is the number of platelet that should be present in a single unit of blood. So the dose required is 1 unit of random donor platelet per 10 kg body weight. If the patient is 70 kg body weight, 7 units should be given. If the child is only 10 kg, one unit is enough. So this will increase the platelet count to about say 50,000. And when the indication for platelet is say there is a different condition in neurologic, and whenever to prevent the bleeding into the eye, and whenever the patient has got fever, the platelet count should be a little higher.
So that particularly about the blood grouping I'm telling you.
Yeah.
So there's an O positive patient who requires a platelets. So should we give only O positive platelets? No? Or talking about platelets in reproductive age? Specific.
So platelet usually the random donor platelet about 90% of the platelet is clear. Whenever the platelet concentrate is prepared in the blood bank, about 90% of the platelet is clear. It is not contaminated with the red cell. About 5 to 10% of the platelet gets
Sometimes they get contaminated.
Yeah, 5 to 10% gets contaminated. When there is a contamination, that is platelet instead of grey in color, clay white color, if it is red color, that means red cell contamination is there. This platelet has to be given ABO specific and RH specific. If there is no contamination of the red cell, then it can be ABO non-specific. And RH also can be non-specific. If there is contamination, then again it should not be given to RH negative person, especially if it is a girls, if it is a women, young women who is in a reproductive age, that should not be given. If it is clear, very clear. Literature says it's quite...
Dr. Dhananjay, I'm very sorry, please.
the consideration of ABO specific, non-specific in the quantity of the plasma that is present is very low, only 50 ml. So the antibody that is present is in low concentration, the reaction does not occur. For example, platelet is given A for A patient, if B is given, actually B contains antibody A. When that is transfused to the A person, actually it can react because the antibody is less. We know that prozone phenomena, very less amount of protein, antibodies, more antigen, no reaction happens. That is the reason we allow ABO non-specific. When for single donor platelet, of course, because it is coming from a single donor and a large quantity, about 200 to 400 ml plasma, that contains more antibody.
So it is group specific.
So it should be a group specific.
Group specific. Yeah. Thanks a lot, Dr. Sundar. Panel we say should have 4 to 5 people and this, but I'm seeing a lot of consultants, and Dr. Dhananjay is one who is a nephrologist who uses the blood for the dialysis. I think he's in a hurry, he's going off. Just out of the panel, I just request you to please come over here and talk about the packed pretzels that you keep using, because we supply packed pretzels to people who are at Bapuji Hospital also who undergo dialysis. They come to me if they're known to me, so even without replacement I keep giving blood to them also. Lakshmi, one more chair for Dr. Dhananjay. Yeah, please.
Thank you very much, madam. Thank you for involving me. We tend to use packed red cells a lot. That is out of compulsion we use. As nephrologists, I don't like to use more of blood or blood-related products. But our patients are not much affordable. They don't take erythropoietin injections regularly. They don't get dialyzed well, and even the iron profile estimation is costlier for them. So what they do, they keep coming with their relatives every 2 or 3 months and ask for donation, ask for transfusion once their hemoglobin gets low. So in such patients, we do tend to use packed RBCs. And in multi-organ dysfunction, as Madam rightly said, we use all products like platelets, FFPs and others. But if anemia of chronic renal disease, if it is managed well, it can be managed without the need for any packed RBCs.
Thanks, Dr. Dhananjay, for highlighting. Yeah, how often you use erythropoietin is a question for you from Dr. Sundar.
So we usually start with 4,000 units of erythropoietin injections weekly, and it can go on to 12,000 units per month. After that, we change.
Affordability.
Yes, madam.
Affordability.
Cost is a major limiting factor. For patients like ESI or some other health insurance, it's not a problem. But for the people who spend from their pocket, each erythropoietin injection will cost between somewhere between 600 to 1,200, 1,500 rupees.
So there's a take-home message also from Dr. Dhananjay's information here. All of us need to have a health insurance. Very, very important. Otherwise, most of the things we may not afford.
It's very important for doctors to have health insurance.
Thank you, Dr. Dhananjay. You keep going for blood donation camps. I'm very happy to say that SS Blood Bank is #1 in voluntary blood donations. This is the statistics available which we got from the district, and I think minimum of 3 or 2, I should say, blood donation camps we have every month. And most of the places, when we go to colleges, there's so many voluntary blood donors who just come, who voluntarily come to donate. But there are a lot of girls also who volunteer But most of the time we find at least 25 to 30% who are so much interested, so much enthusiastic to donate, but the criteria for a voluntary blood donor, a same blood donor, it doesn't fit into that criteria. Maybe it's a weight or anything. So in such cases, sometimes we do say that let us take penny bags and collect at least 100 ml from them. So they would be very happy. And the use of penny bags, whenever I think of penny bags, it's Dr. Prasad, who keeps telling us to keep penny bags. We do keep penny bags. So it's over to Dr. Prasad about the use of blood collected in the penny bags. We are apprehensive to collect and keep because pediatric department always requests for fresh blood. They say fresh blood, fresh blood. I don't know what is this fresh, 24 hours. So if we just collect and keep this blood in penny bag, 100 ml, so it is not used, it is neither useful for an adult patient nor for a pediatric age group. That goes just with. But it's really a good idea. So whenever they require, maybe we can just read and give. But we can get these patients these donors who come to the blood donation camps. So to highlight, to throw light on this, over to Dr. Prasad.
Thank you. The whole idea of penny packs means small packs. If you bleed as a donor, if you bleed the donor, for one donation you can make 4 to 5 penny packs of packed cell volume and remaining plasma also. Because the requirement of blood volume in neonates or pediatrics is less. In neonates, when it comes to indications of blood transfusion, whole blood transfusion, there are 2 indications. One is when it comes to RH incompatibility, where mother is RH negative, baby is RH positive. If the baby starts showing the indications of like acute drop in hemoglobin and acute rise in bilirubin based on the criteria, if you have to decide extend transfusion, yes, we use whole blood. Imagine yesterday's night scenario. They called me, baby's hemoglobin is 6 gram at the age of 12 hours. Bilirubin is rising already by clinical, not yet done this total bilirubin. And the baby looks yellow till to the knee level or leg, that means the bilirubin is more than around 20. If it goes to the foot level, it's around more than 20. So if that clinical scenario, I guess I asked the duty doctor, yes, this baby needs blood and extend transfusion. Then the question came, whole blood, yes, whole blood. Then the question came, sir, is it fresh blood? Yes, it's fresh blood. Which blood, sir? Then start scratching. So the blood, when it comes to whole blood in this scenario, we try to give, in emergency situation, O negative blood suspended in AB plasma, they say. If that's not available, she said, it's not available, sir, it's more than 5 days, then no use. So then try for B blood group. So then she asked me, sir, can I give baby's blood group is B positive, we know that. Can we give blood group B positive, blood group is available, can we give that? Sir, I'm arranging for that. No, please hang on. If you are giving B blood group, in this scenario, you can go ahead, B blood group, but that has to be RH negative again. If you give B positive blood group, already there are antibodies transferred from the mother in the baby's blood. If you give B positive blood, if you have given B positive blood group, then the hemolysis will continue. You are not doing any justice there. So you have to give ORH negative blood, emergency, suspended in AB plasma, or B group RH negative blood. These are the ideal ones. Since both were not available, they said it was more than 5 days blood is available. That doesn't help. Why that doesn't help? Because if you give the long stored blood, already there is derangement in the electrolytes. It can cause dyselectrolynemia when you are doing extended blood transfusion, which is double volume. It takes 1 to 2 hours, and during that procedure, dyselectrolynemia can cause problem with the baby, hypokalemia or hyperkalemia cardiac. Number 2, in stored blood, it's more than 1 or 2 days, 2 or 3 days, there is something called 2,3 DPG in the blood. If you remember the basic physiology, integrate your basic physiology again here. So where you need physiology, anatomy, biochemistry, pharmacology, pathology, and microbiology. You can't deny those, leave behind them, and you can't become a good doctor. So your 2,3 DPG goes down in your stored blood. If that goes down, again your shift goes to left. Your oxygen carrying capacity goes down. You may doing extended transfusion to bring down the bilirubin to prevent conductors, your basal ganglia toxicity. The same thing, you are not improving the blood carrying capacity of the oxygen. Patient may go for hypoxia. situation like this, that's why we ask fresh blood, please, fresh blood, try to get it. So the fresh blood was not available. Fresh blood was not. So it's difficult. I mean, I don't blame pathologists here. No, they are doing fantastic job. It's not easy to get blood products now. That way, from a very benign donor, now with all these diseases occurring around. So in a situation like this, what we did in this case, no for prolonged blood, continue the intensive phototherapy, quadruple, keep 4 phototherapy, 1 from below, 2 from top, and when you get the blood in the morning, go for external transfusion. Now the blood is there, the appropriate external transfusion is going on. If somebody is interested, can go and see. It's going on now. Started in the NICU. Okay, so that's the second scenario where the whole blood is used is in acute blood loss. Okay, a baby who doesn't receive a vitamin K or due to some reason, on the day 3, day 4, baby comes. The first one is hemorrhagic disease, and now the scenario is hemorrhagic disease. Don't confuse. Where vitamin K has not been given to the baby, which occurs most of the time in peripheries, and this baby comes on day 2, day 3 with acute bleeding, gut bleeding, mucosal bleeding, intracranial bleeding. Where there is acute bleeding, baby goes for acute anemia. Yes, if you can give whole blood. The whole reason is the whole blood contains plasma and it has all your coagulation factors. And if somebody is worried about the overloading of the blood, is whole blood, if you have the group specific packed cell volume, you can give packed cell volume along with fresh frozen plasma, which has got all the coagulation factors, which are again deficient in vitamin K, deficiency coagulation factors, factor 2, 5, 7, 8, all those things. So you can do those two. So here is a scenario where rational thinking helps. Just 2 minutes, 3 minutes, don't get panic. Sit down, think which blood group to give, what if I give whole blood, which one is better, and what is some addition, subtraction, answer comes to your mind. That's what's called brainstorming, which is when, what, how, why, and how. Brainstorming is not the young doctors when the strong brain is, if they don't get a mobile, now the mobile, if they don't get a message from a boyfriend or a girlfriend at 5 o'clock, they're strong braining. Where is my girlfriend? Where is my boyfriend? That's not brainstorming. Storm your brain. I have read this somewhere. So where is this? What is this? Why is this? How is this? And when is it? You get the answer. If you don't get answer, please do not hesitate to call me anytime for help. I was so appreciative of this young doctor when she called me yesterday night, early morning, today 2 a.m. That was fantastic job she did, because that sorts out most of the problem. We appreciate young doctors who call in the middle of the night when they are in doubt, because here they prove that here is a doctor who is safe and honest. And unless we have a good liaison with hematology department, we can't do any justice to the hemato-oncological problem in our medicine practice. Thank you. I'll come back to the other scenario later.
Yeah. Thank you, Dr. Prakash. Prasad, don't you think some important departments are missing your professors? Anesthetist. There's no anesthetist here with us. Dr. Aruna is on leave, and we could not get anybody from that team. Director is there. I've just considered him as emergency medicine HOD. Okay, to speak. Then physician. The medicine department is like pathology is the backbone of any hospital. So I was just saying, Dr. Sindappa. So when it comes to platelet transfusion, yes, then we are envisioning. So our area, we endemic to dengue. So we encountered a lot of patients with dengue. Of course, pediatric age group, we say, Dr. Prasad will tell us, but there are adult patients also with dengue and other causes who need platelet transfusion. And I need to say that this was when we started components, especially for platelets. This was SS 75th birthday of SS. When he used to come to our college, I told him you need to give something to the public on this auspicious occasion. So we had conducted mega blood donation camps because of SS 75. I said something to the public is the blood donation, the component separation, which was very much essential. Otherwise, we were referring patients to Shimoga, Hubli, and Bangalore. Otherwise, I used to regularly call people of blood bank of Shimoga and then Hubli and even blood bank of Bangalore to influence and request them to provide the platelet. That was a time where we had a lot of problems, and then yes, it was a dream come true for us when all this happened within 1 year. So platelet usage, when it comes to platelet transfusion, I think medicine people, they use platelets, and this is experience what he's using, how much, and what are the cases. I request Dr. Sindapat to throw light on that.
Thank you very much, madam. Good afternoon to all of you. We are getting more of viral fever cases every day, in each and every outpatient day. Minimum 3 to 4 viral fever patients are getting, out of which they are having multiple coexisting diseases like malaria and dengue. We will do platelet count. There are no bleeding points in the platelet count is below 10,000, definitely will advise platelets. Above 10,000, depending on clinical condition, we will use. Otherwise, we are using third generation of cephalosporins and anti-malaria drugs. Along with steroids also, we are getting good response. If it is below 10,000, definitely we will go as per step towards that, depend upon body weight. If they are having less than 10 kg, we will use one. Here all physicians are treating more than 40 kg minimum, 40 kg patients in development. Therefore, minimum we are using 4
units. Okay.
If their blood count is less than, platelets less than 10,000.
Less than 10,000.
No, there are bleeding points in the gums and all at the side of